Well, welcome everybody to Optometric Education Consultants National Webinar Series, Sunday night edition. We're going to have a very nice talk tonight. Ocular nutrition, tying function, structure, and molecular all together. With Dr. Greg Caldwell, who's a graduate of the Pennsylvania College of Optometry, where he also completed a one-year residency in primary care and ocular disease at the Eye Institute in Philadelphia. He is a fellow of the American Academy of Optometry, a diplomate of the American Board of Optometry, a member of the Optometric Glaucoma Society, and a member of the Optometric Wellness Nutrition Society. He currently works in Duncansville, PA as an ocular disease consultant. His primary focus is the diagnosis and management of anterior and posterior segment ocular disease. And he's been a participant in multiple FDA clinical trials. He's integrated nutrition, prevention, and wellness into his patient care and practices integrative optometry. He's a co-founder of Optometric Education Consultants and co-administrator of OCT Connect on Facebook. He has lectured extensively throughout the country and over 13 other nations as well. In 2010, he served as the president of the Pennsylvania Optometric Association and served on the AAO Board of Trustees from 2013 to 2016. He's president of the Blair Clearfield Association for the Blind. So please give a warm virtual welcome, Dr. Greg Caldwell, as he talks about ocular nutrition.
Thank you, Joe, and thanks everyone for attending tonight. I wasn't sure what the attendance would be like, and I was pretty surprised by how many people registered for this topic. Disclosures. I'll hit the highlights here. The content and the activity was prepared independently by me. You can see there's a whole list of Alcon to Santen, Allergan to Inova, whether they're advisory boards or companies I've lectured for and received an honorarium. I don't really put that up there to really impress anyone. It's just a guy from Duncansville, Pennsylvania that has an education company, needs to stay connected, and that's how I stay connected with what's coming out here. I don't have any financial proprietary interest in any of the companies mentioned in this presentation. I do want to highlight that towards the end, I'll be talking about the scanner. There is a non-salaried financial affiliation. The Involve, I do sit as the PA medical director for that credentialing committee and the special unit investigations. That's a managed Medicaid in Pennsylvania. I sit as the chairman of Council for Diabetes and Macular Degeneration. I have to add the AMD to the healthcare registries. That is an outcome-based registry, which is pretty cool. That's probably the most important one. The content and format of this course is presented without any commercial bias and does not claim any superiority of any of the commercial products or services that I talk about. And I think you guys know Joe and I have own optometric education consultants. Joe is a great partner. I do want to pass this along. I was lecturing in Atlanta about 10 days ago, and it was for the AACO, the American Association of Corporate Optometrists. They had this booklet, and they had Stuart Richer in here. He was talking about zinc and so on and so forth. I want to thank Stuart Richer for all he's done for optometry. I'm not sure. It's a sad piece of news that I'll pass along. He passed away probably about 10 days ago, maybe 2 weeks now. He struggled with, I believe it was lymphoma, but he thought he had it beat, but obviously the lymphoma got him. So he was a huge pioneer. He was probably the founding father of ocular nutrition and optometry. And I do want to say thank you for all he's done. Keep his family and him in your thoughts and prayers. So here's my practice. Again, this is why I try and stay connected. Here's the building, which we own. We have electronic health records. We have an optical, lots of fun equipment. But, I am a clinician first, then a scientist. And some are scientists first, then clinicians. And, what I need to do for patients is need to be able to simplify things for patient and patient care. Science is awesome. I love science. I just geeked out with a guy at the academy. He got his PhD in trabecular meshwork. But there are clinical applications. He taught me a lot about the trabecular meshwork. But if it doesn't have a clinical application, it really doesn't do much. And what I try to do is is bring the clinical application to a lot of this science that's out there. And Sarah kind of wrapped it up. This was one of the nice little texts I got that, it's wonderful to have someone who's juggling many aspects, science, clinic, teacher, lecturer, and it was very nice. So Sarah kind of summed it all up there for me. So that's the practice. The agenda, here it is. It's in the handout. I'm not going to read it to you. Here's a question for you, and this is what I want you to put in the chat box for me. How many people were killed on this day here? We all remember this day, 9/11. How many people were killed in 9/11? Can someone put that in the chat box? It's not a polling question, so I'll look at the chat box. There we go. Good. The answer is 2,996 people. So the people putting 3,000, yes, just 4 short of 3,000, 2,996. And the reason why I bring that up is with those who were living, and most of us probably on here probably had that visceral feeling. We all remember where we are. It changed America, kind of united us for a little bit of time there. But the point is that was 2,996 people. And what we see, this was again at a lecture, is that, we have 1.5 million people with heart attacks and strokes in the United States. 800,000 die from cardiac disease per year. And when I divided that out, that's 4,000 a day, heart attack and stroke. And then we have, 2,192 from CAD here. So, we have this amount every day dying, but, we kind of redirected our lives, and that was a terrible event. Again, for it was 3,000 people. I'm not making any light of that, but yet we don't have this visceral feeling for the heart attack and strokes and the chronic diseases that are out there. So hopefully this will help maybe redirect what we're doing kind of in the United States that's out there. My career has been in ocular disease, and it's really been rewarding. It was about 5 or 6 years ago where patients were asking me, should I take resveratrol? Should I do this for macular degeneration? Should I do this for diabetes? Can I do this for glaucoma? And they were reading about it, and I'm like, I don't know. I kept getting sick or tired of saying, I don't know. Go ahead. It shouldn't hurt. It's fruits and vegetables. It's antioxidants. So I started doing some digging, and it was like unearthing a tree. And I found a couple cool conferences that I attend, and one's coming up here, and you'll hear me reference it a couple times. It's coming up in December. But I teach how to do spectral domain interpretation and angiography, visual fields, teach how to do macular degeneration and glaucoma. And I've been focusing on structure and function, but it's been nice to be able to fold in this nutrition side, and hopefully you'll get a little bit out of what I've learned from some of these other conferences that I attend. So with that, the first polling question is, are colonoscopies and mammograms prevention? Or colonoscopies and mammograms prevention? And let's get that launched. All right. So, yeah, I agree, Chad. Too many. Yeah, it's a great answer. Too many. Did it get? I think we might have stopped it, Joe. Let's see here if I'll relaunch it. We might have both launched it at the same time.
I think we did.
All right. So let's. Hold on. I ended it. Relaunch. All right. It's launched. Are colonoscopies and mammograms prevention? Poll is up. Lost the question. I have someone putting an A in there. Yes. The poll is open. Look at these. You guys are pros at this. Look at that. 80% already. Thank you for making this interactive. All right. We got a lot to get through tonight. So I'm going to end the poll. I'm going to share the results. And all right. We have 55 saying yes. We got 40% saying no. It's kind of a tricky question, weird question. Maybe you can say a prevention of death, but it's really not prevention, right? When I go and take these vitality anti-aging courses, obviously this is not prevention, because if you detect a polyp that has cancer or a lump that's cancerous, it's not prevention. Again, maybe prevention of early death, but you have the condition. So it's more early detection, right? So early detection, this is what patients are expecting now. Early detection, wellness, and prevention, right? And that's even a harder one, right? Because now where's the allopathic side to prevention, right? Like, where are the studies? How do you do a study on prevention that's out there? But people are coming in now and they're saying, okay, I don't have diabetic retinopathy. I don't have macular degeneration. My dad has 43 injections. What can I do that's out there? And this might be a person in their 30s. So how do you go about trying to have that discussion? And remember, Joe Deloche is going to be one of our speakers here coming up. I believe it's December 11th. And I sat through one of his lectures and he went through the generations, right? We can't treat the baby boomers when it comes to this, like the Gen X, like the Gen Y and the Gen Zs that are out there. They're all different when it comes to, like, I don't want a pill for that ill. Can you give me something else? And hopefully tonight will help us out with that. Here's something that came to me as an epiphany probably about 4 weeks ago. Is that we have all this early detection. I was walking through the exhibit hall, and we have this Rabin cone contrast test that can help with glaucoma and diabetic retinopathy, maybe function loss, and that's the function side of this lecture. Here's a ERG VEP test being done, and look at this retina and the signaling. You're going to see me talk about the inner and outer retina a lot tonight. Then we have dark adaptation. We have dark adaptation with 2 units. We have OCT with early detection of drusen. And what we're doing is we're getting so far out. Like when I graduated in 1995 from PCO, did the residency, and I was treating glaucoma, we really did stereo disc photos in visual fields. Nerve fiber layer and GCC, which then came even later, wasn't a part of my residency training. It was something I had to learn later. And what we've done is we've moved detection up so early, like dark adaptation, 3 years before a drusen forms, but we don't have like an allopathic treatment. And I'll explain that as we go on. So my point is, and I'm working with the states, at least POA, and kind of coaching them like, yes, we need to keep going for lasers and all this fancy allopathic stuff, but really we better get the optometrist comfortable with ocular nutrition, because the end stage disease docs, like some of the retinologists, right, they're doing injections. They're not really worried, concerned about prevention and early detection. So the instrumentation, the diagnostics are getting there, but you're going to hear me reference a lot. Stress the body. That's through exercise. Let it recover. That's sleep, maybe meditation, yoga. And then you got to fuel it. And that's what we're talking about tonight. You got to fuel it with some good nutrition. So this is one of my funnest slides. This here will help start to make the rest of the lecture come together. This is like a cell membrane, right? We all remember the phospholipid bilayer membrane, right? And you can see that it's lipophilic, fat loving in here, water to the outside. The extracellular matrix would be out here, right? This is the extracellular matrix. Remember, cells talk to each other. They signal each other. This is the cell membrane. Now, the issue with the cell membrane, remember, it's fat loving. So omega-3s, omega-6s, you need to have the right ratio. Everyone throws omega-6s under the bus, they're not inflammatory. The body likes to be in homeostasis. It needs to be balanced out by the threes. That's why I take about 2 or 3 grams of omega-3s throughout the day to get this cell membrane pliable, right? And when I do this live, I usually ask, is vitamin E fat or water soluble? And usually the audience knows that vitamin E is fat soluble. So if it's fat soluble, where does it deposit? It deposits itself into the cell membrane, right? So if the cell membrane is too stiff and not ready to be laced or embedded with these antioxidants, that's where the omega-3s come into play. But when I was talking to some really powerful people in anti-aging, and I said, which is, the chicken or the egg? They still feel bringing down that oxidative stress is important, but not far behind, in a Kentucky Derby type of thing, a horse heads behind is getting that cell membrane so that it can be prepared for the other fat soluble. And we have water soluble vitamin C that goes to the outside of the cell, right? That interstitial space to the inside of the cell. And then there are other fat soluble vitamins that are out there, which I'll point out right here. And the ones that a short, very small list would be like beta carotene, lutein, we're familiar with that one, and lycopene. Now, this here is a cell that is ready. This is a cell that is protected, right? This is not the way the American diet sets up, right? The standard American diet, we always hear the acronym SAD. This is the way most of our cell membranes look. And this is setting us up, as you'll see me go through here, setting us up for that chronic burn that we have that's out there, that chronic inflammation. America is great at acute inflammation. We're not real good at chronic inflammation in our body. So let's go through and kind of point some of that out tonight as we go through. Like a comprehensive antioxidant support, when I talk to the patients, these are some of the things like, yeah, we're going to support that cell membrane. We're going to support the immune system. You're going to see tonight, macular degeneration is pretty much a breakdown of the immune system. And that's why we do genetic testing. And you're going to hear me talk about complement factor H. Then I'm going to show you some chronic inflammation on some OCTs. What we're trying to do is we're trying to give support to that oxidative stress that's in that extracellular matrix. And the cells talk back and forth to each other. So we're supporting that kind of cell signaling that's out there. And that's why you need a comprehensive antioxidant support. People think that I'm a big naysayer of lutein and zeaxanthin. I am not. There is a reason why it's the highest level in our fovea. I'm not even going to say the macula, but it's called a macular pigment. But in our fovea, it acts as the third lens of our eye. It helps protect the cones that are in the foveole. It does give some protection. I'm not taking that away. But that's in the inner retina. You're going to see tonight the macular degeneration is in the outer retina. It's the third lens. It helps us see better. It helps with the contrast sensitivity. It helps absorb the light. The cornea is the first lens. The crystalline lens is the second lens. The fovea pit, that's why it's a pit. And it has a little coating in there called, the macular pigment for those absorption to give us a really, really good vision. So when I like to talk a full antioxidant support, we're giving cell membrane support. We're supporting the immune system, supporting the oxidative stress that's occurring in the extracellular matrix, and helping support that cell signaling. Now, with that being said, we never stop sharing. We'll launch this. You got it, Joe, or me, so we don't end up.
I do.
Okay. So do you consider yourself an integrative optometrist? Yes, no, or I'm not sure. Yes, no, or I'm not sure.
And during the last poll, I launched the handouts. 2 forms, same handout, 2 forms.
Yes, I see them there. Thanks, Joe. The bigger one's going to be the full slides, the 8.9, I guess what's megabytes. And that'll be the full slides. And then the 2.7 will be the 6 per page. All right, we're up to a high number. I'm going to end the poll, share it. And that's pretty cool. We have 52 saying yes, and about half, not really sure, where you've heard me reference it, maybe what's going on. And we have 23 saying no. So who in here considers themselves an integrative optometrist who has done supplements, vitamins, AREDs, omegas, which could be EPA, DHA, maybe meibomian gland? Have you done vital tears, regenerize? Have you performed amniotic membranes? Maybe CBD doesn't have much of a ocular usage, maybe for some pain. Have you ever given anyone probiotics that's out there for any ocular condition? If you have, you're an integrative optometrist. You just didn't know it. It's usually about 10% of the audience when I ask it live. And then whenever I say how many have done this, and then I ask the question again, then the whole audience raises their hand. They just didn't know what they were doing, right? And the reason why I bring this up is because none of this stuff is allopathic, right? Omega-3s is not an allopathic. I'm going to explain that shortly. Vital tears, you're taking someone's blood, spitting out the serum. Regenerize, using placenta-derived anti-inflammatories, amniotic membranes, a placenta, AREDs and vitamins and supplements. This is all naturopathic, and you're integrating it into your allopathic treatments that you were taught when you went to optometry school that was out there. So these are all naturopathic in a sense. So allopathic, and I'm not going to read this slide to you, but you can see it's using medication, surgery, radiation. You're kind of doing opposites cure. But when you get down into complementary or integrative medicine, you're doing homeopathy or naturopathy, maybe chiropractic care, Chinese medicine. A lot of it, what we're going to talk about tonight, is kind of naturopath, or using 8 to 10 servings of fruits and vegetables out there. So a lot of us are already doing this complementing. You know, I still give someone a full antioxidant support, something with resveratrol, as they're getting their anti-VEGF injections, and it complements. I'm not going, alternative medicine. Hey, don't get your anti-VEGF injection. I'm saying, hey, look, this will complement. This will help go in and be a natural anti-VEGF to kind of help what the retinologist is doing that's out there. So it's complementing, or you're integrating into, the medicine that you're already providing that's out there. So you're going to hear me reference a lot tonight about allopathic treatments. That's whenever we use antibiotics and steroids to treat and lowering the IOP. I'm an allopathic doctor, but I'm an integrative doctor because I'm integrating a lot of this naturopathic ways, hypochlorous acid, Avenova, all that stuff. That's all naturopathic. Then when we are using to, you're using it to Clearadex to kill a parasite from Demodex blepharitis, it's tea tree oil. It has a way to inhibit that parasite that's out there. So you'll hear me reference, chronic and low-grade inflammation. When you look at the life expectancy and the health expenditure, you can kind of see right here how this kind of tails off for the United States. This is using some world data here, and you can see the rest of the world is kind of up here, right? And here we are over here. They're good at chronic and controlling that inflammation. It's that French paradox. They drink wine and eat cheese, but don't have much cardiovascular disease that's out there. Here we are here. So there's some things that we could probably fold in to our ways as Americans. So like cancer and what I like to call slow burn diseases, identifying these conditions early, right? Early detection, prevention can make a difference, either full recovery, or dramatically reduce the quality of life, or reduce the patient's, improve the patient's quality of life, or even death. And in this case, it would be vision or blindness, right? So when you have this chronic inflammation, it's like going to Vegas, spin the roulette wheel. You have this low chronic inflammation in your body. You get pulmonary disease, cancer, cardiovascular, Alzheimer's, diabetes. These are all kind of your chronic, low, slow burn diseases that's out there. So with that being said, let's stop this polling question. Joe, can you get polling so we don't have what we had before? Polling question number 3.
I'll get that for you, Greg.
We have choose your parents wisely. We hear that a lot. And so, like, hey, I got these genetics. What part of genetics cannot be influenced by lifestyle? Is it 100%? Hey, I'm kind of stuck with what my parents gave me. I can't change 87 to 90%. I can't change, 48 to 50. I can't change 8 to 10%, or 0 can't be changed. So where are you with that? Choose your parents wisely.
Nothing to check, Greg. All caught up.
All right, I'm going to end the poll. I'm going to share the results. All right, let's see. We have people saying right in the middle of the road, 50-50 out there. Is 55% are saying 48 to 50%. We have 11%. All right, let's see where I'm going with this. All right, choose your parents wisely. It's not as true as we used to think it was. When I go to these anti-aging conferences and you hear us talk about epigenetics that's out there, the exposome, depending on what you read, 8 to 10%, or who you listen to, 8 to 10% you can't change, right? You're kind of stuck with that. The other, say 90 to 92%, is what you do to yourself, right? And the 3 pillars, and it gets even deeper than that, but for tonight's talk, you got to stress the body, which means I'm not 10 patients behind, but stress your body, get on some bike, go for a jog, go for a walk. But then if you over exercise, that's not good, but you got to let the body recover, right? That's your sleep, your heart rate variability. That's, how much deep sleep did you get? All that, what's your heart rate when you're sleeping? That's recovery, meditation, yoga. But then you got to fuel it, right? I have some of these people that come up into the, when I get to some of these conferences, and, they work out all the time. And I'm a big proponent of the hand scanner, and they'll put their hand on it and go, yeah, this is junk. Look how ripped I am. I'm like, well, yeah, you burnt through all your fuel. You don't have anything. I can fly a plane from New York to LA and land it, and the plane looks beautiful on the outside, and let's take that plane off to go to Hawaii. But if it doesn't have any fuel in it, I wouldn't want to be in that plane. So, so it's not about being ripped and muscular. It's what's happening internally with our bodies. So there are biomarkers out there. Biomarker is a test that has meaning. We do it all the time. A visual acuity is a biomarker. IOP is a biomarker. Heart rate, stepping on a scale, how many pounds do you weigh? Blood work. There's all kinds of biomarkers that are out there. I have a continuous glucose monitor on right now because I kind of want to see what my sugar does and I'm not a patient with diabetes. Not that that's a bad thing, but I've been getting into this and playing around. My blood sugar right now is 89. I just looked it up. So I got that. So that was good. I got to work out today, and I have my Oura ring on, measuring my recovery. Those are all biomarkers. There are predictive biomarkers that are out there, and you can see hemoglobin A1C. So if you go to kind of more of a concierge doctor, a doctor that's into prevention, they usually will have you get these tests. Hemoglobin A1C, how's your sugar, your long-term sugar? How's the inflammation in your body with a chronic reactive, with a C-reactive protein? How's your plasma homocysteine, right? Get too much of that, you start getting blood clots. Vitamin D is a hormone. So a lot of people don't realize that hormones work kind of down at that nuclear level, and that's why vitamin D is important. Omega-3 index, right? Not cholesterol. How's your omega-3 to omega-6 ratio? And we'll try and clarify some of these carotenoids tonight, because we do seem to kind of cross that in eye care. And I'll kind of hopefully unravel some of that, what it means when you have low carotenoids, when we get to that point. Biohacking, that's why I got some of this stuff I'm wearing. Biohacking is the art and science of changing the environment around you and inside you so that you have more control over your biology. And here Dave has said it's someone who uses science and technology to make his or her body function better or more efficiently. So that's what biohacking is that's out there. So here, I've been reading a lot outside of optometry, and here's the annual review of nutrition. And it said, hey, ocular carotenoid status, getting sloppy with the mouse. Ocular carotenoid status and health and disease. This is from the annual review of nutrition, and it talks about carotenoids play to be a key role in retina disease. And down here it says it may or should be considered to be a part of the comprehensive eye care. And, carotenoid status in humans, most of us are which focused on the eye, can be measured in various tissues. You could do it with skin, blood, and in the brain. That's kind of what I really want to do it there. But carotenoids are important. It's a biomarker. Here's one of the things I want to keep repeating. We have different ways to measure carotenoid levels. You can do that through blood work. You could do it through an M-Pod. There's other instruments, and you have the skin scanner. But here's the kicker. When you score low, it's not that just by dumb luck that day that you're just low in carotenoids. The studies have shown that you're low in all the antioxidants that are out there. So that's really the key with that. So, as I mentioned, I like using the hand scanner in the practice. Unfortunately, this is where I see a lot of my kind of standard Altoona patients, right? It's the standard Altoona diet that's out here. We don't have a lot of fish, so we're not lucky like Joe and Lori where they live in Sarasota. And when I went to visit them, I had like 6 fish to pick from. You went Cajun or blackened and so on and so forth. We don't have that luxury in Western Central Pennsylvania. And what happens is we have patients come in with these low scores. It's indicating their carotenoid level, but it's indicating that they're low in all the antioxidants, and that's what the studies have shown. And what it's doing is setting them up for this chronic low-grade inflammation. Something systemically can happen, and there's lots of eye conditions. The big ones that we'll talk about tonight are glaucoma, macular degeneration, and diabetic retinopathy. You want people to have their scores. My score used to be here. Now my score, well, this is probably my hand on here, but recently with all the travel, I've dropped down to about 56,000. Now I'll get that number back up. So DNA is DNA sciences, genomics, all of our genes, genetics, individual gene, the individual genes that we're going to reference, and then epigenetics, the study of how our cells control the genes activity without changing the DNA, right? You hear of methylation that's out there. It was a great article I saw. A friend of mine, Jennifer Purdy, she had it on LinkedIn, and it was talking about methylation. It's not good. It's not bad. It's just good and bad in some areas. And that's what we're talking about, is turning on genes, turning off genes, genes that are set up to give us cancer. We want them turned off, but the genes are set up to protect us. We want them turned on. So that's your epigenetics. And when I was taking this, I go to this conference. I'm excited to go. It's coming up here in a few weeks. It's called the A4M. It's the American Association of Anti-Aging. That's your 4Ms and medicine. It's in Vegas. It's a MDs, DOs, pharmacists, registered dietitians, optometrists. that go there because when they got into healthcare, they thought they were getting into healthcare, but it was sick care because everyone goes to the doctor when they're sick. They wanted to get into prevention, early detection, and maybe help patients out. In that capacity. So I learned this word, exposome, right? I was there and I was listening to this lecture. And so I just Googled it. And here's just a Google definition. The exposome can be defined as the measurement of all the exposures that an individual has in a lifetime, and as how those exposures relate to health, right? So again, it's just another way of saying your epigenetics that's out there. And you can see that there's just a whole bunch of influences, whether they're internal or external. So I do some genetic testing in the practice, right? What do I do for that patient that comes in and says, hey, my mom is this or my dad is that with macular degeneration? They have all these injections. So I feel comfortable now making kind of these lifestyle recommendations. So I genetically test. And you can see here when it comes to macular degeneration, they look at the ARMS gene, they look at the complement factor H and complement factor 3, right? So here are the complement factors and here's the ARMS. And you can see this person based on their genetics is low. I'm going to ask this patient here, that is how I'm going to ask all the patients, but I'm going to really help them with their lifestyle, especially this person that's high. I'm going to have them kind of do that Mediterranean, if you want to say, type of diet, maybe supplement, make sure they get exercise, they're not sedentary, make sure they're getting recovery, and then fueling in a good way that's out there. Now, here I want to point out complement factor H, C3, this is an immune disease, right? You hear me talk about when you do antioxidants, you support the immune system, the cell membranes. Well, I'm going to show you, this is immune down here. Watch what happens. This is my buddy. I love listening to him. He's on YouTube. If you want to go learn again about the immune system, the innate immune system, the adaptive immune system. Down here, we have the innate immune system when something comes in and how our body reacts. But then over here, we have T cells and B cells, and you can see all the interleukins. And he talks about how this all works in the natural killer cells. But right here in this whole, he talks about complement factor, which I kind of zoomed in right here. You see these complement factors, you have complement factor 4 and complement factor 3, and and it makes this membrane attack complex. It's another part of our immune system. It's kind of like a stick of dynamite. It goes into the cell membrane of the bacteria. And it's not a B cell, it's not a T cell, it's the complement factor system. It's part of our immune system that's here. And if you look, I love this picture from this article where it talks about complement factor H, right? It's that gene profile, right? If you have that gene and you have complement factor 3, it's in the RPE. Remember, this disease, macular degeneration, is in the outer retina. Again, this lecture is tying structure, function, molecular, all together. And that's what I really like how this lecture came out, because now we're talking about C3, C5. This is a genetic allele that a person has. And this is putting them at risk, and it's in the RPE. And if you have these lifestyles that turn it on, or you can have a lifestyle that tries to keep that immune system from going awry, and then that's how you can help protect patients with macular degeneration or that are predisposed with macular degeneration. So in doing a lot of the talks and talking about nutrition and so on and so forth, you come across this, high zinc, low zinc. Should I take it? Am I a believer? Am I not a believer? Here are some things that's out there. I'll let you guys make the decision, here. This is the National Institutes of Health. This is the National Eye Institute. You can Google it and go there right now. It talks about frequently asked questions. So this type National Eye Institute, AREDS/AREDS2, frequently asked questions. what is the basis for concentration of zinc in AREDs, right? And it said AREDs had 80 milligrams. And it says here, some experts recommend a lower dose. Investigators did not find a difference in the effects, right? In the effects of 20 versus 25. So to me, it's okay to give a lower dose of zinc with this formula that is now I'm going to highlight is only for intermediate and advanced macular degeneration. Why are we talking about that? Because there are studies in 2015, there are studies in 2018 that show when you have, and it says right here, patients with 2 complement factor risk alleles, complement factor H, risk alleles, and no arms, the progression with more zinc containing components compared to the placebo. And it talks about the higher dose zinc promoting choroidal neovascular membranes. Okay. That's what the studies are showing out there, that genetics play a role, and the high dose zinc can lead to choroidal neovascular membrane. Now, the Academy of Ophthalmology comes down here and says, oh, genetic pleomorphisms of complement factor H and complement factor and ARMS too doesn't really help and shouldn't really influence you, but when I looked at some of these docs, some of them were on the AREDS 2 study. So, just like anything, when there's controversy, the truth probably lies somewhere in the middle. So that's what they're talking about here, right? You go way back here, we're talking about, see, the complement factor H, the C3, here's the ARMS, here's the complement factor. We showed how it works in the RPE. And then we talked about the 25 milligrams not really having an effect on the outcome. And we talked about that. So with that being said, you can launch this poll. This was a 63-year-old woman that comes into my practice. She has drusen. And so I ran her genetics on her. Her ARMS is low risk. She has 2 high risk complement factor H's. The study says 2 complement factor H's and no ARMS puts the patient at risk for increasing choroidal neovascular membranes. Would you prescribe a high dose zinc supplement? Knowing this, would you say, go right ahead? There's studies out there showing it. Take that 80 milligrams of zinc. Looks like the chat room is pretty quiet right now, so that's okay.
It is. There's nothing going on. People are just engaging in your discussion, Greg. Just listening.
All right. So this is a little slower here, right? Not as people aren't as responding as they're putting some thought to it. This is where the controversy is out here with zinc, right? So this is, do you buy into the zinc? Do you buy in that it needed to be 80 milligrams? I'm not here to tell you which way to go. I'm just trying to show you where the controversy is out there. And I'm going to end the poll. I'll share the results. And here we have 70% and 30% saying they would still do it. No right or wrong answer, in my opinion. I steer away from it when I have genetics. I was talking to Jerry Sherman, and there was a nice lawsuit up in New York that a patient caught wind of this, and she had wet macular degeneration in one eye. She was kept on the AREDS 2 formula, and she had a good eye. And over time, the good eye went to wet, and she found this material, and she went to suit and won the lawsuit. So after hearing that, and that's not the only one, I decided that when I genetically test and I see this type of pattern, I'm not giving the 80 milligrams. But again, I'm just trying to teach you guys where to fish, not to tell you what to do. All right. So January 27th, I was lecturing in May 20th, 2022, I was lecturing down in Nashville. And Melanie Clemens, who's into nutrition, she was talking about this cardiovascular doc who had a heart attack. And he went on some diet and took some supplements, and he was able to reverse his coronary artery disease, right? These type of plaques is very similar to what builds up into the retina. And here I am in April 27th through January 26th of this year, 9 months. This is before down here showing drusen, that inflammatory, that complement factor C3, ARMS, and complement factor H, inflammation. And I'm not getting this in every patient, but there's probably genetic profiles. You can see I'm very particular on where this is. And this was cube data, and I had it all lined up. And you could see this is an RPE scar, the drusen reversed. And I'm not getting on 100% of the patients, but I'm getting it quite frequently. Here was a patient here, and you can see I've tried lining this up as close as I can. I wish I would have got this over or whatever happened, but you can see here, this is before. You can see January 21 of 20, and this is after. And you could see the drusen, and I scrolled down through, it's not anything trickery here. That you could see drusen. Now, this is where it gets really controversial, and it's not really controversial. You'll hear me talk about this is inflammation. This is small drusen. AREDS 2 is not indicated for this patient. It's not intermediate. It's not advanced. And without genetic profiling, I wouldn't prescribe a high dose zinc. But I hear colleagues say, "Oh, it's not controversial." There's an inflammatory genetic issue going on with this patient. Do something, right? Get the patient exercising, get them eating, get them wearing sunglasses, get them on what you should do is a full comprehensive antioxidant support, because the disease is in the outer retina. I'm going to show you that the macular pigment is in the fovea here coming up, and we want to do something that treats that outer retina that's there. Joe,
Greg,
I
before
see
you
a
get
whole
too
bunch of
far,
stuff coming. Yeah, I see it blowing up. I figured that would be it. So go ahead. I'll let you take it.
Are you aware of the correlation of high dose zinc and risk of Alzheimer's?
Am I aware of it? I am aware of it, but I don't know the percentages that are out there, right? The beautiful part about the eye, if you think about it, why does it correlate so well with like rheumatology and and the diseases? The eye is a ball and socket. It has a Tenon's capsule, which is collagen and elastin. It's got skin. It's got neuro, which you're going to see me point out here coming up. So neuro. So again, Sarah, no surprise, right? The high zinc in the risks of Alzheimer's that are out there, because some of these things at low levels are good, but at high levels become toxic, right? It's like, going out with friends. You have a couple beers and then someone says, bring on some, Fireball, bring on the tequila. Now, you had a good thing going with a couple beers, and then someone had to get crazy. Now everyone is sick. So I don't know the numbers, but yes, I am aware of that.
What about the association between zinc and diarrhea? Is that causative or anecdotal?
Yeah, I'm not sure about that one. I know magnesium can certainly create diarrhea. I'd have to look that one up. That's out there. So I'm not familiar with that one, Joseph.
Are you suggesting 25 milligrams of zinc or no zinc?
No, yeah, the body needs zinc, right?
High risk.
Yeah. So high risk, I'm saying, no higher than 40. That's out there. So that's what would be my recommendation would be. The body needs zinc. COVID has taught that, right? So zinc, and zinc is great for fighting the flu bugs and all that fun stuff that's out there. And viruses. And so I'm not saying no zinc. I'm just saying that if someone's high risk, I would just probably go with a little lower zinc that's out there.
Which one has the higher dose of zinc, AREDS or AREDS 2?
I'm not sure. I mean, Joe, if you want to maybe look that up, or someone wants to look it up, AREDS 2 became the favorite because it took out the beta carotene again, which is another tricky one. Beta carotene, given at those levels, promotes cancer. Beta carotene at a lower level actually inhibits cancer, right? So when you look, and I think maybe I had it back here, these are some pretty high percentages right here. Vitamin C, 833%. Vitamin E, 667%. Zinc, 167. Now, you put copper in it because, again, when you do certain things, zinc depletes copper. Copper's just in there because zinc at that high level depletes the copper. And then there's selenium in there, then lutein and zeaxanthin. All right. So someone put in there, Joe. Thanks, Jeff. They both had 80 milligrams of zinc. All right.
Now, Greg, what pathogen actually telling patients to stop the zinc?
Say that again.
What pattern of genetics are you telling patients to stop the zinc? This is a question that came in a little bit earlier.
Yeah. Again, I'm not telling them to stop zinc. Okay. So let's go back and let's look at the study here. You just want to go with a lower zinc, right? It goes back to have a glass of wine, don't drink the whole bottle, right? So have a couple beers, just don't, have a shot of Fireball, just don't drink the whole bottle of Fireball or you'll be sick, right? So I'm not telling anyone, not to do zinc. The genetic profiles that are out there, if I can go back, I think I have to go to that one right here. If you want to look these articles up, but it always is focusing on the complement factor H. If they have too high risks and nothing in arms, then you want to go low zinc. I didn't say no zinc. I said low zinc on those patients. And this would be the genetic profile, right? Here's the gene. Here's the SNP that they're looking at, whatever that is, single nucleotide polymorphism. And they're looking at the alleles. Remember, there's the G and the A's and the C's and the T's. And so when you go and you look at this SNP with a GG, it's low risk. That's the negative. You come down here, the allele of CC, high risk, GG, high risk on this SNP, on this complement factor H, this SNP, high risk, this complement factor H. This one is saying high risk. That's two positives. That's what this is saying here. And low, this is the one that sets them up. Do I routinely ask patients if they have acid reflux since conditions can block absorption of vitamins? Yeah, sure. I mean, there's a lot of things that we can get into with, gut health, so on and so forth. We can certainly turn this in to a 6-hour lecture tonight. So yes, I mean, there's lots of things. Have you had bypass surgery, Crohn's disease, all these different things that we can ask to see how absorption would take place. So yeah, are they eating fats? A lot of these things are fat soluble antioxidants. We don't want them to take them on an empty stomach. A little bit of butter, a little bit of milk, a little bit of something can help them with the absorption that's out there. Great questions. All right. So oxidative stress, right? So when I went to my anti-aging conference, I loved listening to this guy, James Lavelle. He was talking about aging, performance, and vitality. And what he kept trying to do is remember, everyone's an individual to start out with. There's oxidative stress, there's hormone balance, right? And that's when I start talking about thyroid. It's insulin, it's cortisol, it's thyroid, it's the sex hormones. They're all tied together. We can't break them down into individual components when you're trying, like they were talking about, this one lady was laughing like, oh, they were trying to fix their thyroid and they were insulin resistance. I picked the insulin resistance, the thyroid, numbers got better. So it's all kind of tied together. The stress hormones, cortisol, glucose. Again, we were talking about hemoglobin A1C and insulin resistance. And again, hormones, the gut integrity. That's a whole other lecture that I might put together. The immune balance, the environment and the exposure and the burden. Again, everyone's an individual. With that being said, if we could use the chat box, I don't have this as a polling question. We're looking at this line right here. This is the RPE. There's a little black space, and there's this little hump right here. This, what do we call this line on an OCT? Right above it, there is a black space, and then there's the external limiting membrane. So I'll give you a little anatomical. There's the external limiting membrane. Right below it, this is actually called the myoid zone. Then there's this, what are we calling this? Use the chat box if somebody would be out there. What are we calling this line right here? Then there's a black space and then the RPE. The inner and outer segment, the ellipsoid zone, the photoreceptor integrity line. Right. That's exactly the what we see that's out there, right? That we used to call it the inner and outer segment of the photoreceptors, the ellipsoid zone. Right above it's the myoid zone, the photoreceptor integrity line. Now, being a geek of OCT and wanting to know why this hyperfluoresces and this hyperfluoresces, why is the ellipsoid zone changing its name, and why does it hyperfluoresce? So the ellipsoid zone is formed mainly by mitochondria within the ellipsoid zone of the outer and inner segments of the photoreceptor. So the iOS is nothing more than mitochondria, right? Mitochondria are super important when you go to anti-aging and vitality. They talk about the mitochondria. You know, you got to baby those mitochondria. And it makes sense. It's the powerhouse of the cell. And that's why when this starts to break down, you start losing visual acuity. The powerhouse of the cell. The ellipsoid zone is nothing more than mitochondria of the photoreceptor. The photoreceptor is from the external limiting membrane to where in that one picture I showed you where the complement factor H is, to the tips of the anterior, or the anterior surface of the RPE. This is all photoreceptor. And here, the myoid zone is the endoplasmic reticulum and the Golgi apparatus. And this is like the cell you're looking at, right? It's really cool. Cell membrane, inside nucleus, mitochondria, the organelles. We're able to see the organelle of the mitochondria. Really, really cool. I geeked out when I saw this. We have OCT Connect. There was a doc that put this on. Here's what the study that they're referencing in July 2020, interpretation of OCT and OCTA. And you can see here, went through and labeled all this stuff. I geeked out when I saw this right here. This is the RPE. Look at the mitochondria of the RPE. They're right here, right up against Brooks membrane. I want to push that out. We really want to highlight that. It's right up against Brooks membrane. And that's going to help you. Probably the easiest way to meet Thai nutrition is we're kind of really good at it from allopathic-ish, or we're okay at it, I guess, with allopathic within optometry. But remember, mitochondria here and mitochondria here. Mitochondria are important. They produce energy from organic matter. They live about 100 days. They produce 90% of the body's energy, but here's the kicker. They produce 90% of the body's free radicals. And then they can become dysfunctional when there are clinical consequences. So just to kind of show you, the brain has 1.2 million per neuron, heart has 5,000. Photoreceptor that I showed you, the ellipsoid zone, it has about 500 per cell, but the RPE, and these are where they are right here, the RPE has about 700 per cell. Now, when I went to my anti-aging conference and the Vitality, the A4M, and they've been around for 30 or 35 years, this isn't like something that started, they talked about inflammaging. And I'm like, what the heck is that? And so I had looked up inflammaging, and it talks about the consequence of failing mitochondria and how it leads to the levels of pro-inflammatory cytokines, tumor necrosis factor alpha, interleukin 6, right? Interleukin 1. We hear about all these different, doesn't that sound like dry-eyed? Interleukins, doesn't it sound like inflammation? Sure. The inflammaging is mitochondria, in a sense, inflammation. And here's the doc that was in it. He was talking about dead batteries, the role of mitochondria dysfunction in immunological decline, emerging diagnostic tools, and nutraceutical interventions. So the mitochondria is super, super important. So polling question number 5, Joe, I'll let you do it so we don't end up where we were. Do you agree that free radical formation progressive progress that leads to cell damage or maybe death, cellular damage or cell death? Do you agree that free radical formation is a progressive process that leads to cell damage or death?
It looks like we're all caught on the chat there, Greg.
Thank you, sir.
Zinc was a hot topic.
Yeah, it usually is. It usually is. Yeah, it gets confusing out there. And, I just try to kind of pull it all together because I was confused after going to different lectures. So, all right, let's end that poll. We'll share that result. And that's pretty cool because I believe a lot of the audience here, 91% say yes. And there was 7% going, I'm not sure. And that's why you're here tonight. So, let's do a real quick, antioxidant or free radicals. It's basically there's an unstable electron shell that's out there. And then what happens is when you have that free radical, the body likes to be in homeostasis. It steals an electron from something, and it's usually a healthy cell. So the free radical will go to a healthy cell and steal that electron. Remember when I showed you way back at the beginning, the cell membrane, and it needs to be laced? Well, that's what those antioxidants do. When they embed themselves into the cell membrane, the free radical gets balanced out. If you don't have enough free radicals, it damages the cell, right? And that's what we see, oxidative damage, oxidative stress. And we always see this picture here, the beautiful apple, you cut it in half, and if you don't put any fresh fruit on it, which is nothing more than vitamin C, that's out there to protect it as an antioxidant, it'll begin to turn brown, and then you have death, right? You can see this right here. You can see this cellular death and happening. I'm going to show it to you on an OCT in a few slides coming up here. So free radicals are the bad boys, right? There's all kinds that are out there. You have superoxide, peroxide, all kinds of free radicals. And how we're supposed to balance them out is through our fruits and vegetables. We just showed that we get it through aerobic respiration, right? Our body gets them through producing energy. We get them from going out into the sunlight, right? You get a good tan, you're getting free radical formation. And the way our food sources are set up, the way we eat with that standard American diet, we quickly get more free radicals in our body, setting us up for diseases. You hear me talk about food sources. Someone sent this to me. An orange of 1950 takes 21 oranges of today. I just saw a lecture at the academy. Someone had up there something like 43 bowls of spinach. Well, if it's 30, if it's 40, if it's 25, it's still, you need more spinach today than you needed years ago with one bowl of spinach. What people don't realize is the antioxidants, those are what are the protection to the fruit, right? So when the fruit is in the ground for long periods and during cold nights, sun, harsh weather, this and that, it's the carotenoids, it's the antioxidants beyond carotenoids, it's the polyphenols, it's the resveratrol, it's the quercetins that are in the fruits and vegetables that build up. And when we grow them in greenhouses and we grow them quickly, they don't get a lot of nutrient value. It's their own protection. And then we go and eat them and get the benefits. That's the way the system was set up. So when you have all these free radicals, it's supposed to be the rainbow, but sometimes the rainbow of fruits and vegetables are not nutrient dense. I thought this was kind of funny. I was walking through the Marriott on October 23rd last year. And I just kind of looked down and I had to take a picture. I chuckled. Person got some breakfast. Looks like they had some eggs, some bacon, some potatoes, covered it with high fructose corn syrup, and left all the antioxidants behind. I just kind of had to chuckle watching that. So they maybe got some good proteins in there, but then they covered it with all this high sugar ketchup, and then didn't help balance out with the good fruits that they're. And maybe they're not very dense, but it would have helped out just a little bit. And then the M Lounge. Yes.
Greg?
Yes.
Are we to assume that you didn't let those antioxidants go to waste now, did you?
Oh my gosh, you know the answer to that. I picked that fork right up and choked those right down. So being an antioxidant person that I did. So I had a strong immune system, so I wasn't afraid. All right. So I've traveled a lot. I'm in the Delta Lounge a lot, and I've watched the Delta Lounge transition over to like healthy food. It used to be all this kind of processed food. The M Lounge is trying, right? You got some watermelon, but then you got some processed high sugary stuff here. You got some fruits, and you got some ultra processed foods here, maybe some peanuts, but in there's some M&Ms. The hotels, and we're trying in the United States. Now, nutritional antioxidants. There's exogenous antioxidant. Exogenous means our body can't make them, right? So there's vitamin E, vitamin C, the carotenoids, polyphenols. We have well-known vitamin C, beta carotene, lutein. We get hung up on this. It's great. I'm not saying we shouldn't replace the inner macular, the macular pigment in the inner retina as the third lens. It's just limited on the protection. It has protection. We just need to make sure. I use lutein and zeaxanthin, but it's an add-on to a comprehensive approach, and I'll show you why in a second. So neutralize free radicals. This is what antioxidants do. All antioxidants neutralize free radicals, repair oxidative membranes, decrease the reactive oxygen species. Now, with that being said, Joe, if you can do polling number 6, can our body manufacture these antioxidants? Vitamin A, vitamin C, vitamin E, carotenoids, flavonoids, resveratrol, polyphenols, quercetin. Can they manufacture them? And chat box looks pretty quiet, and we're good. Got a good amount of people weighing in. I think the trend has occurred. And so we have 10%, 11% saying yes, and 81% saying no. So we have about 20% saying or 19% saying yes or I don't know. So that's the key here. That's what we need to chat about. We have endogenous antioxidants, and you can see them here listed. And you can hear a lot about glutathione and, ubiquinone that's out there, and uric acid. If you get that too high, that's not good. That's gout. And then we have some enzymatic ways of getting endogenous, but the fruits and vegetables, we can't get them, right? There's all those, the audience, the polling, the 81%. Spot on. Vitamin A, vitamin C, E, K, beta carotene. I'm not going to read this whole list. The polyphenols, the flavonoids, we have to get them through our diet. And that's the important part. Our body makes the free radicals. The fruits and vegetables are to balance that out. The whole comprehensive approach that's out there. So remember, I said this earlier, the comprehensive antioxidant support, it supports the cell membrane. You're supporting the immune, that extracellular matrix oxidation, the cell signaling that's back and forth, all super, super important. And again, there was this here, flavonoids, vascular implications. Flavonoids increase nitric oxide, blood flow, lessens blood flow restriction. The American College of Cardiology. This was in another lecture. I just snapped it. This was, again, Melanie Clemens. She was talking about the the importance right here. I thought this was a great slide. She shows you that it's limited to just the inner retina and kind of that foveal area. Again, it's important. It absorbs the blue light. It helps with glare disability that's out there. And it gives a little bit of protection to those cones that's out there, or maybe a lot of protection to the cones, but not the disease of the whole retina and not where the disease is. And get some, but you're getting, that disease is in the outer retina where those mitochondria are. So, carotenoids are 600 in nature, 50 in our food chain, 15 to 25 that are found in our bloodstream. And the highest concentration of lutein and zeaxanthin are found in our macula. And I've already explained, where they come or why they're important. So the question that I have, Joe, if you do polling question number 7 is, do you, I'm curious, measure carotenoids in the office? You could do it through blood. You could do it through skin. You can do an MPOD. You can ask for serum levels. There are instruments, OCT-like, that are out there that are nice instruments that can measure carotenoids. All right.
And we're still good on chat, Greg.
Perfect. And we got a nice 83%, 84. We're going to end that and keep rolling along. And I'll share the results. And that's usually what I see when I do it live. We don't have a majority of us are not doing it, which is fine. That's why we come to education. So measuring carotenoids. So again, we saw this earlier in the annual reviews of nutrition saying, maybe eventually it may become an integral part of our ophthalmological care that's out there, measuring carotenoids. Now, the significance of carotenoids, I stole this from another doc that was talking on this. And, you could see here that carotenoids are all over the place. You're talking about cardiovascular disease. We're talking it here in vascular aging study. Here we know it about macular degeneration. This is talking about non-Hodgkin's lymphoma, fruits, vegetables. That was more of the fruits and vegetables and the antioxidants. Low levels of carotenoids increase the risk of HPV infection, oxidative stress, rheumatoid arthritis. The idea is when your carotenoids are a biomarker that you can measure. And the key is that we've been kind of led to believe, or we kind of maybe led ourselves to believe that when you're low in carotenoids, that we just want to replace with carotenoids. But I'll show you there's studies out there that show basically it's a biomarker. When you're low in carotenoids, they have shown that you're low in all the antioxidants. It's like anything else. You got to take a history. Maybe a patient's taking vitamin C, or maybe they're taking vitamin E. They might not be low in that antioxidant, but the key, they're low in everything else. And that's the key that's out there. But you see, carotenoids are studied because in the link, it's just kind of tying it all back to nutrition, because you can measure them in a relatively easy way, usually a blood test that's out there. Now, I'm going to do polling question number 7. I have the same thing up here. Let's see what happens. Maybe I screwed it up. Joe, launch polling question 8. Maybe I just didn't change the number. What I want to ask the audience, we can use the chat box, is I just want to see in the chat box here is, nope, I didn't put it in there. So we'll stop that one. And we'll relaunch that. So we'll use the chat box. All right, everyone, everyone's used to typing. Get ready. Is the macula this one orange, or is the macula blue? Is the macula orange, or is the macula blue? Orange or blue? All right. So I see a lot of blue rolling in, a few oranges. And the macula is actually the blue that's out there. The blue is the macula. It starts at the fovea, and you go 2 disc diameters, start the fovea, 2 disc diameters, 2 disc diameters. So the macula is pretty big. This is kind of like maybe the fovea with a little bit of pair of fovea. And you'll see that's just about where the macular pigment is. So the macular pigment is limited to there, meaning lutein and zeaxanthin to the inner retina, and the macula is that big. And really a drusen anywhere in that area is considered macular degeneration. And I put this in there for your notes. You can see the macula, how big it really is. And then down here, you can see where the macular pigment falls. And remember, the disease is down here in macular degeneration. And I focus on macular degeneration, but this is huge for glaucoma. This is huge for diabetic retinopathy. This is really huge just overall for just overall health and all those connections that we talked about earlier, Alzheimer's, dementia, cardiovascular disease. I thought this was kind of neat. This was Alan Glazer's a friend of ours, Joe and I, and he said, hey, hop on to ODs on Facebook and make some comments. You guys are pretty smart, help, really elevate the ODs on Facebook. And so Chad here puts loss of foveal pit with macular traction, drusen appearance, which is vitelliform, Amsler normal, Who sends the retina? Who monitors? And it definitely has drusen here. You can see what our colleagues, this reference of ODs on Facebook, monitor. And then over here, monitor. This person got really, really creative, and they put one of those GIFs of a monitor that rotated. I just caught it at the wrong angle there when I screenshotted it. But, they're talking about monitoring, right? Monitor. There's a lot more we can do for this patient than monitor. I agree the epiretinal membrane is there. I'm not saying epiretinal membrane pill, but this is inflammation. There's an inflammatory reaction going on down there in that Brooks membrane. We see oxidative stress all the time. We see it on an OCT. Remember I told you we were going to see this apple and we're going to see the cellular damage that from this oxidative stress? I got a better one coming up for you here. Look at this oxidative stress going on right here. Watch this mitochondria line, how it fades and becomes white, and then it fades. And there's some blood vessels blocking it there from above. You can see it fades, and it's hyperfluorescing and fading. When it fades, it's this. When it's missing, it's this. You're seeing oxidative stress right here. This is good. This is bad. Oxidative stress. When it's missing, it's dead. When it's missing, like through here, it's dead. Dead photoreceptors, no mitochondria. You're seeing oxidative stress. You're seeing this change right here in this retina. This is this apple. This is oxidative stress, oxidative death. Right here, you're seeing on OCT. This is an RPE scar happening. So there's tons of inflammation coming on in this outer retina. And we see it here, oxidative stress. And I kind of skip back on this one here. This is oxidative stress. Again, it's the apple. We see it all the time. This is just terrible disease. This patient's going to have bad visual acuity because their mitochondria are failing. Now, this is one of the things that we've learned from maculogics when dark adaptation. Look, here's the bottom of the photoreceptor. Here we are with the RPE. Remember those 700 mitochondria? Here's Brooks membrane down here. And look, this is where the disease starts. Dark adaptation that's why we do dark adaptation, to try to identify this before the drusen show up, right? That's what we're getting so far out in front. What's the allopathic treatment? We can't do AREDs on this. This isn't intermediate. We got to do lifestyle. We got to do sunglasses. We got to talk nutrition, maybe supplements with this patient. Wear sunglasses outside. You could see now the RPE and the mitochondria are becoming stressed. Maybe that complement factor H, that complement factor 3, if they're predisposed, is now being turned on because they had the genetic profile. Then you get more stress. That's that apple dying, right? Still no drusen, and now you got the drusen formation. And remember, this is where the mitochondria are. You got mitochondria, the photoreceptors, mitochondria, the RPE. You have an inflammatory reaction, chronic low-grade inflammation with this disease that's out there. Now you have the drusen formation. And a reminder, the mitochondria are here and the mitochondria are here. And that's why we want to protect them, right? There's the mitochondria again. And the disease is a progressive disease. Prevention is here. Early detection is here. We are able to see the drusen here. We feel comfortable. We need to feel more comfortable intervening with this disease here, along with glaucoma. Now, I know I'm getting close to about 15 to 20 minutes before I got to wrap up. Let's try and make this quick, or I'll just move on with it. But, the Beckman classification, is there anything here that bothers people? Is there anything in here that bothers this? Now, granted, it's 2013, but we still use it today, the Beckman classification, no AMD, early AMD, intermediate, advanced, using the size of the drusen. Are there any pigmentary? And this is where AREDS 2 is indicated. I would say if you have it, use a low dose zinc. But again, you guys can decide what you want to do. Anything out there that's bothering anyone? I don't see it rolling in. I see some other stuff. Here's what I'm going to tell you that bothers me. You have drusen, and we called it no AMD. You've got inflammation, and we're calling it no AMD. It would be like, October is over, and I was having fun with this during, or not fun, but you get what I'm coming to. Not that breast cancer is fun, but in October, when I was lecturing, I was utilizing it. I was saying, okay, back in the day, we used to do digital exams to try and find a lump. Now we do mammographies to get that early detection, not prevention, but early detection. And it'd be like saying, well, in this classification, we found a lump, but you can't really feel it for your finger. So we're going to call it no breast cancer, right? It's too small. We're not going to call it macular degeneration. No way. No, that's inflammation. We're going to wait for it to get a little bit bigger, and then we're going to try and intervene with some AREDS too. All right. So this was, I thought, was pretty cool here. I showed you this a little bit earlier, and this was my reply right here. Right. Why didn't we ask this patient if they smoke? Why, smoking sensation is part of that. Like we saw some, hyperreflective columns here. That's showing some damage to the RPE. We're talking diet and lifestyle to these patients. And you could see I wrote a nice long reply there. Now, we would say this. Here's a patient with has diabetes, but the dilated fundus exam and the OCT doesn't show disease, but the OCTA does. There's oxidative stress going on with this patient. And we could see it finally, it was happening here, but it's not happening here. We need to be intervening and helping these patients. Here's a foveal avascular zone expanding, but their blood sugar might be controlled. Can we step in? Sure. Exercise, recovery. Can we do something nutritional wise? And the answer is yes. Can we intervene with glaucoma? The answer is yes. That's out there. So here was one. And again, Paul Charles and now the late Stuart Richer did this in 2015. I love this from the diffuse study. The diabetes visual function supplement study, diabetes, here it is, oxidative stress, look, inflammation, either death or inflammation, diabetic retinopathy. And they went across and they showed in this table that these antioxidants can help mitigate diabetic retinopathy in animals. They block capillary cell death, improve retinal capillary fragility. That's what happens in diabetic retinopathy, reducing VEGF. And there's 1, 2, 3, 4, 5, 6 of these that reduce VEGF, reduce oxidative stress, and you could read the rest right there. So you want to have a full range of of treatment, right? Diet, the people that are in the diet say, well, you should have to do it through diet. You shouldn't have to use supplements. Well, I bet you I've changed more diets by using supplements, because the patients then go, well, I'm taking a supplement, I might as well get the salad instead of the French fries this time. And there's all kinds of studies, nutraceuticals and diabetic retinopathy. I lecture for ARI before they got bought out by Alcon. This is right from their slide deck. I didn't do anything. They're showing healthy trabecular meshwork, oxidative stress. There it is again. And it shows the stiffness to the trabecular meshwork. Guess what's getting damaged there, ladies and gentlemen? The receptors. And that's why you start piling on medications and the medication doesn't work. Things like Vyzulta, they put nitric oxide. If the nitric oxide receptor is damaged from oxidative stress, you're not going to get the outcome that you're looking for. And can you use it for your glaucoma? The answer is yes. There's studies out there showing it. Here's the overlay of a nerve fiber layer. I just put these slides together, so I'm going to see how I can walk through this. We're very good at looking at the nerve fiber layer, looking at the ganglion cell, and we can see here that we can see ganglion cell. We can see how healthy it is, and we can see that it's damaged here in glaucoma. Now, remember, it's the ganglion cell. Here's the ganglion cell, and the ganglion cell is right here in the retina, and then it goes through the nerve fiber layer, through the optic nerve, through the lamina curvosa, and through the canal, through the foramen, and eventually synapses in the lateral geniculate body. That's a long neuron made up of cell membranes, made up of mitochondria, made up of different organelles. And you could see here, it needs nutrient. And it was talking, right here, it's a retinal ganglion cell, the optic nerve. I thought this was kind of neat. Mitochondria dysfunction factors, immune system related, genetic factors, right? Immune system, that's what antioxidants help against. You heard me say it helps support the immune system, helps support the cell membrane, biochemical that's out there. So pretty neat tying this all together. This one here, I thought this was kind of neat. This is from LinkedIn, and this person is showing what does the nutrition have to do with the brain? And here's that cell, ganglion cell, and the axon, right? And it's showing here that it's myelinated, and then it synapses. This would kind of be like this whole neuron and then synapsing. And behind the optic nerve, remember, it gets myelinated. And so look at all that's needed. Homocysteine metabolism. You need all the B vitamins, blood flow. This is now talking about brain, but doesn't that kind of make sense what's happening in the eye with these neurons? Polyphenols, flavonoids, EPA, DHA, vitamin D, polyphenols, flavonoids. Here's neurotransmitter, energy, nerve pulse, membrane, right? We talked about membrane earlier, the EPA, DHA, omega-3s, but it also needs C and E, all these other kind of fat soluble kind of antioxidants. And this was Sissy talking about how an atheroma forms, but look right here, oxidized LDL. If we could prevent them from getting oxidized, then you get that T cell, right? That adaptive, that again, it's about the immune system. We want to control the immune system from forming this kind of scar that happens in the smooth muscle. All right. So treatments for macular degeneration. We want to stop smoking. It depletes. That's the first thing your body triages. It doesn't allow the antioxidants to go to where they belong. It depletes them. You have to do lifestyle changes, control those systemic diseases. Are you taking AREDS vitamins? Are they right for me? AREDS 2 benefit people with intermediate and late. I want to press upon that. It's intermediate and late. So they're high dose nutraceuticals. You want to do it for the proper person, the intermediate. Now, here's that polling question. I'm going to relaunch it, Joe. I have it up here. Relaunch, and here it is. All right. So during the AREDS 2 study, were patients allowed to take multivitamins? No, they were testing the efficacy. Yes, and when you read it, about 10% were. Or yes, when you read it, okay, they said, well, let's do 50-50. Or yes, there were 90%.
Greg, there's a couple of things that did come through the chat. How often do you follow patients with drusen and drusen alone, the macula?
Yeah, it's a great question. It depends on the stage of it. Obviously, the more advanced, the more oxidative stress. I'll be following them maybe every 2 to 3, 4 months, looking for that choroidal neovascular membrane. Tiny drusen, it could be 6 to 9 months. So it all depends on the stage of it. That's a great question.
I see many middle-aged patients with RPE modeling, but no drusen. How do we manage these patients?
Yeah, it's just a sign of oxidative stress that's out there. To me, it's a sign that there's inflammation. I would consider, I do the hand scanner, measure their levels, and then if they're low, I'd probably recommend that their body's showing some types of stress. So that's kind of a tough one, but I'd have to look at maybe some other OCTs to see what else was going on.
How would you manage a subfoveal drusen?
Subfoveal as in above the RP. What's that called? That's a help me out, Joe. It's not the drusenoid. It's the other type of drusen that's out there that is high risk for reticular. Thank you. So if they're talking about reticular drusen, same way, it's inflammation. It's just in a different location. All right. I want to try and land this in about 9 minutes. I'm going to end the poll. I'll share the results. And this is usually what I see when I do it live. They were washed out 50% of the audience, and then 50-50 is usually what the audience says. Here's the answer. Just go to the National Institutes of Health, and where I showed you before, frequently asked questions. And can I take multivitamins if I'm taking AREDS 2? Yes, you can, because in AREDS 2, 9 out of 10, or 90%, which 9% of the audience answered, 9 out of 10 participants took multivitamins. So whenever you have a patient that comes in and you say, hey, you should be taking AREDS 2, we probably should be saying, well, maybe a multivitamin 2, since 9 out of 10 were in the study, we're taking a multivitamin if you want to match it up. It's not me. It's right on the frequently asked questions in the National Eye Institute that's out there. All right. So there's, this is what drives me crazy. I hear our colleagues say, controversia flourishes. No, it doesn't. If the patient has drusen inflammation, treat them as if they have inflammation. It's like saying, oh, we know how to treat it if they're stage 3 or 4 iritis, but when it's 1 or 2, cell and flare, it's controversia flourishes. No, there's an immune reaction. There's inflammation. Intervene with these patients that are out there. There's different ways to measure macular pigment. Chris, I usually have Chris Putnam's name on here. I'm not sure. Chris, if you're listening, I apologize, but I usually have Chris. He's the one that kind of taught me. He's an optometrist and he got his PhD in macular pigment. So he and I geeked out one night and I said to him, I said, how do you get the true macular pigment? He said, macular biopsy. And that was a joke. So hopefully you got the joke there. We don't want to biopsy the macula, but we have all these different ways that are out there. Clinical imaging, subjective. We could do, as you heard me talk about, serum testing, and we could do the skin testing. Now, let me just show you. Here's the macular pigment. This is where it is when this disease right here. I am a believer that we need to increase the macular pigment. I'm not a poo-pooer against lutein and zeaxanthin. We need it. It's important. God gave it to us in our highest level. Here it is again, but what's it doing over here? Right? That's why 9 out of 10 people in the ARED study were taking a multivitamin, something comprehensive that's out there. And then you can target with lutein and zeaxanthin if you want. Here's imaging lutein and zeaxanthin. Here it is right here. It would be right here in this. Here it is again. This is, you can look at the studies. It's not Greg Caldwell. It's just kind of showing you it's in the inner retina. And remember, this disease is in the outer retina. And here's another one. Here's the macular pigment. And again, here's the macular pigment. The whole other retina needs to be covered. All right, you guys got that. All right, when it's cold outside, what's good for your head and feet? I want to keep moving along here. A hat and boots, but I think we forgot to cover everything else. So we're really, really good out there with lutein and zeaxanthin. Again, they're wonderful molecules. We need them. They're great all over the body. We just need to give them some other support. All right, so oxidative medicine and cellular longevity. Carotenoids, polyphenols, augment and help with oxidative stress and inflammation. Got outside of some of the optometry magazines looking at oxidative medicine, the benefits of polyphenols and carotenoids. This is what Stuart Richer was big about. He loved resveratrol. It helped with mitochondria environment. It helped with the inflammatory mediators and cytokines. It's a natural anti-VEGF. And that's why we see sometimes that maybe it should be a part of our eye exam someday. So I measure carotenoids in the office with the biophotonic scanner. And again, non-affiliated, blah, 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 with Pharmanex out there, just full disclosure. I do have an OptiView as a full disclosure in my practice, and some of the other instruments, the Hiru, I have that for dark adaptation. That again, I speak for the companies. So the biophotonic scanner, it measures carotenoids. It works on Nobel Prize winning Raman spectroscopy. It measures it in the skin. It's a biomarker of health. You can measure macula, you can measure skin and serum, and there's been plenty of studies that have shown that if you measure it in the skin, and as long as they're not taking any other supplements, it's going to match what's in the serum and it's going to match what's in the macula. And again, it's taking the phospholipid bilayer membranes where these fat soluble carotenoids build up, and then it gives you a correlation of what is going on. It was developed by the National Institutes of Health, and then it was used for macular degeneration and cancer research. Pharmanex came along. They said that their nutraceuticals absorb, blah, 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 blah. They bought the global rights to it. So I like it because they didn't make the scanner. They saw it and then acquired the global rights. How does it work? Yellow and blue make green. You have blue light at 478, not 479, not 477. That is very specific for the color of carotenoids, and it bounces back green light. So, and again, 100 studies out there showing that it's a biomarker of overall fruits and vegetable intake. There was an ARVO study that showed that the objective hand scanner is better than some of these MPOD devices. There's the study if you want to reference it. Again, this is what we're doing. When you score low, this is the way your cells look. When you score high, that's the way your cells look. Pretty simple. Low, high. And this is what you want whenever you're trying to protect yourself from oxidative stress. So are you taking supplements? Well, are you taking good ones? Let me show you. Here's a great case, and I'll be wrapping up here pretty shortly. I'm going to watch that 3 minutes pretty closely here. So we have 53-year-old man. Family history of macular degeneration. Dad has 43 injections. Pre-diabetic, hemoglobin A1C. My exam was perfectly clear. He passes dark adaptation. He wants some type of prevention. So he measured right here on the hand scanner, 26,000. That's low. This is an A+, A, B, C, D, F. This is where I used to be. So I said to him, look, you're good here. What I know about cell membranes, oxidative stress, cell signaling, we probably should get your number up at least to 40,000 and higher. We can do that through diet. We need to change your diet. We got to give you some exercise, stress the body, get some recovery. We got to get some nutrition. So I put him on this, right? This is Life Pack through Pharmanex. A lot of people will say, well, geez, it's only got 1 milligram. I need a 10-to-2 ratio. No, you don't. When you have all the other support, I was watching Joe one time pick up 100 pounds. He could do it, but it was, a struggle. I said, Joe, let me grab some of my friends here. And we all picked it up pretty easily, a lot easier than when he was doing it by himself. When you have all these other antioxidants, you don't need a 10-to-2 ratio. So you can get away with 1 milligram or 2 milligrams a day when you support it with all the other casts. So I supported this patient with everything, a full support. This is what I do for all my ocular patients. He wanted to do something else, so we added some EPA, DHA, cell membrane, D3, K2, there's some astaxanthin, some more lutein, and his score went to 33 and then went to 46. And if we go back and look, he was 12, 20. So that's about a 5-week period that he got up to 47. I don't exhale until I see people here. If you're down here, you got the slow grade burn going on in the body. And with that, you can get, and I have more than 3, this is just 3 in this, you can see drusen disappearing. This is great. We caught this early. We had drusen disappearing. I have drusen disappearing, and I'm starting to see this, right? Since this is longer than we have gone before, especially in the left eye, I asked him to keep a close watch. I hit this person hard, try to get that oxidative stress, that VEGF stress off, and complemented, integrated. And the retinologist even said, since this is longer than we've gone before, so this has been pretty cool to watch these ones roll in from the retina specialist. So I screen everyone in my practice. I try to do anywhere from children all the way up to geriatrics. And we think we all know nutrition and our food sources are bad. So carotenoids and antioxidants, it's more antioxidants. Remember, carotenoids, if you measure, it's just an overall take of what's happening to your body. So I used to be here. This is my score. I got to here. And then now here I am, Greg Caldwell. I sit right here. Now, this was back in October. I just measured the other day. I'm sitting like right in here because all the traveling I recently did. So I didn't do too bad. I supplemented and ate well while I was traveling. And now I'm introducing the Peloton bike. I love. I have no financial interest, but I'm getting that stress part back into my life again. So I can rebalance that good sleep with stress and good nutrition. So thank you for the opportunity. Do this for yourself, do it for your family, do it for your staff, do it for your patients. And with that being said, I'll see if there's any more questions, Joe. And
there are a few more questions, Greg.
Okay, I'll launch this poll while that's rolling in. I just want to see if this presentation helped tie all this together. Okay.
Okay, I think we probably both.
Okay, I got it. It's rolling.
All right.
I was gonna let you do the questions for me. So.
What's your preference for a good multivitamin?
Yeah, again, I'm going to be a little bit self-serving here because I like with the research I've done with the Pharmanex vitamins that are out there. They have a good, they have a life pack. They have what's called a 6S process. The 6 S's sounds like success, but they specify, they have safety are the 2 big ones that I look at. They do studies as another S. That's out there. So it's selection, it's sourcing, it's specification, standardization, safety, and studies. I like that they do. One thing is what really moves me is that they test for what's not in it. Remember, these are plant-based. Heavy metals, lead, mercury, not a lot of companies test for what's not supposed to be in it. They test for what's in it. They'll send it out to independent labs and do all this other stuff, but they're not checking for the lead, the mercury, the heavy metals, the bacteria, the fungus that could be in these medications. So that's the one that I usually recommend. But I also get, when I recommend it to a patient, I also get, paid for it too. So maybe I'm a little biased, but that's the one I like.
Will the patient overdose on zinc if they use an AREDS formulation and multivitamins?
Will they overdose? I don't think that, if they're saying overdose and like death, I mean, I guess you can never say always and never, but it's, we find this out through through, when we gave beta carotene at a very high dose to smokers, it created cancer, right? But beta carotene at a low dose is actually protective. Zinc, there's a high limit out there too, just like everything else that we were discussing. So I'm not sure if you could kill someone. I guess you can if you gork them out.
I think really what they meant by overdosing is put them into a range where they're more at risk for neovascularization or even Alzheimer's.
Yeah, I would say, yes, if you don't know the genetic profile, you got to be careful. Potential if you don't know the genetic profile. And, you guys all know that I lecture with a pharmacist, and some of the things that's coming out is pharmacogenetics, right? We're going to be able to tell, like, hey, don't give this person an opioid because they can become addicted to it, or give this person an opioid because they have pain and they have a very low likelihood of being addicted to it. So, we're going to learn a lot through pharmacogenetics, right? We try to treat everyone, give them 500 milligrams of this, do it 250 of that. Pharmacogenetics is probably going to help us out. So stay tuned to that one out there. That's a good way to answer that question. Is it natural foods better than multivitamins? Absolutely. If you can, I had a patient come in the other day that blew the scanner out of the water. She had 93. I said, what are you taking? She goes, nothing. She pulls up her ring or whatever that, the camera system at home. She had a greenhouse at her house. She literally had a greenhouse, and she gets the manure from the farms and the chicken manure and all this other stuff. She grows her own vegetables. She gets her fish from whatever, and it's like Atlantic wild or Pacific wild caught and so on and so forth. And when I talked to the nutritionist at this A4M meeting, they're like, oh, we should be able to do this through nutrition. Sure, we should. I agree. But again, I've probably changed more diets. I have people coming in saying, hey, doc, you heard me say a little bit earlier, I was going to get the French fries with my salmon the other day, but I got broccoli and then I got a salad, and I eliminated all the greasy foods. And I got some greens, and I eliminated some of the sugars, so they're like, yeah, because I want my score to go up, and I wanted to, if I'm taking any supplements, I want to kind of help out nutritionally. So, everyone's different. You can't treat everyone the same way, but yes, isn't natural foods better if they have the food sources, right? Unless you got to eat 43 bowls of spinach to get the one of 20 years ago.
I think that's about it, Greg.
Yeah, who makes the multivitamin? That's the Pharmanex I was telling you about. So we're going to end it there. I'll make a comment once we get outside of this that's out there. All right. So I'll thank everyone for attending. This will end the CE session.